given unrestricted grants to the pain program to support visiting speakers for these rounds, and our visiting speaker today is a bit of a special guest. This is Dr. Siminowicz is actually a bit of a local guy. He grew up in Mount Forest, did his PhD at the University of Toronto and worked there with colleagues in the University of Toronto Centre of Pain. Went to McGill to do his postdoctoral work, and now, as you'll see from the lead slide here, is at the University of Maryland Center to Advance Chronic Pain Research. He is recognized nationally and internationally as an expert and one of the leaders in this field of using functional imaging to study pain. And we're going to hear today his work on high-end EEG studies. So David, welcome. Thank you very much for coming.
Thanks, Norm, for that very kind introduction. It's been great being here with various different people today and seeing what's going on at McMaster. It's an interesting place, and there's lots of good things going on in the pain world here. My title is not exactly what I'm going to be talking about. The title refers more to the last 5 slides, so you have to wait until the very end. That's my strategy to keep you awake and keep you here until the very end, where I'm going to talk about some of the new pain models that we're working to try to understand some of the changes that we see associated with chronic pain. So that's where we'll start. In my lab, we have several different projects in different areas ongoing, and so we try to find general themes that we can use to link different studies together. And one of the ways we do that is different brain systems and how those are affected by chronic and acute pain. So these are those 3 systems, and I'm going to describe how these change throughout the talk. So we know that the brain changes with it changes in structure, it changes in function. There have been many studies over the last few decades showing this using neuroimaging studies. One of the changes that we see is a shift to limbic circuits. So it's generally thought that pain involves sensory, cognitive, and emotional components. And early on in neuroimaging studies, we were always looking for the changes in the sensory system. Patients are hypersensitive, what's changing in sensory. What we've seen more recently is that these adaptations or maladaptations are actually occurring in other systems like limbic circuits. There's also an involvement of maladaptive stress, so repetitive stress or inescapable stress situations can lead to a vision of pain, lead to a transition from acute to chronic pain. And we also see cognitive dysfunction area that's sort of in my heart. This is the work that extends from my PhD thesis, where I first got into pain and neuroimaging, and that's where I'm going to start. We recently wrote, it's not so recent anymore, I guess, in 2015, but if you'd like to read anything more on what I'm going to talk about in this topic, you can read a review that we wrote in Pain Management a couple of years ago. So pain has a cognitive load. I'm going to talk about a few different brain networks, and I'll describe briefly. So my pointer is visible. I'm not sure if that works on WebEx, but it works here at least. It works on WebEx too, great. When you perform any type of cognitive task, you have activation of cognitive network. That's shown in red. This is what we're going to call the extrinsic mode network. So this could be any type of task. In this case, it's a cognitive conflict task, this group task, or some variation of that is going to activate all of those areas in red. And another network called the deep network, shown in blue, is deactivated. So these two work. Usually one is activated and the other one. So at rest, when your mind is off, mode network is activated. The red extrinsic is turned down. And once you engage these attentional systems, you activate extrinsic mode network, the default mode network. So what we're showing in this experiment, we have a cognitive task with 4 different levels of difficulty, labeled T0 to T3 for the most difficult, and you can see this is the scores corresponding to this pattern of activity. More difficult the task, more activation you get across the extrinsic mode network, and the more deactivation you get across default mode network. So this has been shown across many different tasks in healthy subjects, many different ways. What we showed that was novel was that if a person in the scanner experiencing acute pain, in this case it was electrical pain applied to the left median nerve, you also get activation of this network. And P0 in this case refers to a non-painful tingling electrical stimulation, so they're still feeling something, but it's painful. And P1 and P2 refer to mild and moderate levels of pain. So you can see that the more painful it is, the more activated this cognitive network is. So this to us was the first strong evidence that pain alone can act a cognitive network. And then when we look at everything all together, so now these are, again, the 4 different task difficulty levels. Along with experiencing pain, we see an interaction between the two. So the more pain you're in and the more difficult the task you're engaged in, the more activated this extrinsic mode network is, and correspondingly, the more deactivated that default mode network is. So extrinsic mode network, default mode network, considered the 2 of the major cognitive networks, and we're showing that pain can act as an activator of the extrinsic mode network and default mode network. So this led us to the hypothesis that in chronic pain, in situations of chronic pain, because those were all in healthy individuals, the patients, their cognition was disrupted because they have ongoing pain. So in that case, we don't need to evoke pain while they're in the scanner. They bring their own pain to the game, and now we wanted to see how these the default mode network functions changed. So we did a study in chronic low back pain, and here you see activation in red, deactivation in blue, so corresponding to extrinsic mode and default mode networks again, for control subjects and for chronic low back pain patients. And one thing to notice is that overall the patterns look very similar, so it's not as if patients are doing a completely different task. And in fact, performance on the task was equivalent between the two. The patients can perform just as well, but you do notice that there are some areas of brighter red, and there are some areas where the red extends a little further than what you see in the control subjects. And when you quantify this, you see an increase in the number of voxels activated in the extrinsic mode network in the patients, and a reduced number of deactivations in the patients. And there was one area in particular that came as when we do whole brain correction, and this was the left dorsolateral prefrontal cortex, which showed a lack of deactivation in the chronic low back pain patients. Finding in particular of deactivation of the default mode network is something that's been shown now in a few different chronic pain states and ILAP and others. We're now doing a lot of research on migraine, and using a different task and a different chronic pain population, we showed a very similar effect. So these are, again, work and work activations across patients and controls. And when we compare patients and controls, we again see this relatively increased activation, or actually a lack of deactivation of that same region, the left dorsolateral cortex, compared to the healthy controls. So an interesting thing about these cognitive networks and brain networks in general is that we can use neuroimaging to identify them while an individual is at rest. So here in our low back pain patients, we identified the networks activated during the task, just like I showed you in the previous slides. But we can also, using different multivariate techniques, identify the same networks while the subject is lying in the scanner and not doing anything in particular. And so I mentioned that those two networks, extrinsic mode and default mode, are acting when one is activated, the other is deactivated. And so that's essentially what we're showing here, extrinsic mode network being activated and default mode activated. So this was, the way that we looked at this was a little bit complicated, and I won't get into them. Actually, what we found was a lack of connectivity of the bilateral insula cortex in the patient to both of these cognitive networks. So the insula appeared to be disconnected from these cognitive networks. The insula is an interesting region because it's been strongly implicated in both function and in processing. We also see a lack of connectivity to the left dorsolateral prefrontal cortex again. And we also saw a reversal of that. That's the next part that I'm going to talk about. Is the study was actually an intervention study where we looked at patients 6 months after intervention. And essentially what we showed was normalization of this network. So what's going on? Well, the insula and the dorsolateral prefrontal cortex are involved in a third network that I haven't mentioned yet, called the cognitive control network. And it's thought that the cognitive control network is the network that decides whether mode network is activated or your extrinsic mode network is activated. In patients pre-treatment, that seems to be abnormal. To healthy controls, and following treatment, that normalizes to some extent. So I mentioned that we break up things that we do in the lab into different themes. We can do that by breaking it down by brain systems, or we can also do it based on the methodology that we're using. So this is the second way that we describe our research. So everything we do in the lab use a longitudinal model or repeated measures model in healthy subjects or in chronic pain patients, or in rodents, which I'll get to later on in the talk. So essentially, trying to is how the brain changes to healthy state through acute and the transition from acute to chronic pain. And then once an individual has chronic pain, if we can use an intervention and follow the brain change through recovery and back to a healthy brain again. And the third area is looking at disease-related versus ongoing pain. This question is really about how we see differences between chronic pain patients and healthy subjects in the scanner. Is that an effect of some plasticity that has occurred over years, as long as the pain has existed in these patients, or is it simply an effect of them having ongoing pain in the scanner? So I'm starting with treatment. So the dorsolateral prefrontal cortical changes that we saw reversed after treatment. So these are in our chronic low back pain patients 6 months after intervention, and the intervention was either spine surgery or facet joint block, depending on the clinic where we recruited the patients from. What you can see here is this is actually anatomy, looking at gray matter volume of that left dorsolateral prefrontal cortex. And the blue area represents the area that was thinner or had less gray matter in patients compared to healthy adults. And following intervention, the gray matter volume or cortical thickness increases in all of the patients. You notice that 2 of the patients actually go in the reverse. We didn't have enough patients in that group to really assess what was happening, but those 2 patients were the 2 who did not respond to intervention, who actually did worse following intervention. And what we also showed was that the extent of recovery, or the increase in gray matter volume in that left dorsolateral prefrontal cortex, correlated with the reduction of pain. The less pain you had after intervention, the thicker that area of cortex got. Similarly, the functional change that we saw, the task performance reversed following treatment. So everything seems to be going back to a more normal state following treatment, effective treatment. We also saw in a different population of chronic pain patients using a different intervention again. So this is cognitive therapy, where the outcome is this time instead of pain is pain catastrophe. To change the most with cognitive behavior. I think that occurs before a reduction in pain that would happen at a later date if we were to follow up these patients. And again, we saw 3 areas where there was brain cortical thickening or gray matter volume increases following intervention, one of which was that same left dorsolateral prefrontal cortex, and you can see that improvement in that area was correlated with improvement on pain catastrophizing. So this and other findings from our lab and other labs has pointed to the left dorsolateral prefrontal cortex as a potential for chronic pain. So the reasons for that are that it borders it strings of mode network and default mode network. I didn't get into that, but if you look at the areas that are activated during task and the areas that are deactivated during task, right along the edge, superior frontal, part of the DLPFC is activated, the edge is activated. It's enhanced with patients during cognitive conflict. It changes with treatment, which I've shown. It's involved in descending modulation, or some have referred to this as keeping pain out of mind. So the more you activate this area, the less unpleasant the pain is experienced. It's accessible by neural feedback, meaning that it's close to the surface, can record activity from it easily and give real-time feedback. And it can be targeted by transcranial magnetic stimulation or through other non-invasive brain stimulation techniques. And small clinical trials have shown that this is effective for burning mouth syndrome. And it's also modulated by things like mindfulness meditation, which I'll talk about more. And if you're interested in this topic, Matthew Moyetti, who's now faculty at University of Toronto School of Dentistry, and I published this review article on the role of the dorsolateral prefrontal cortex in acute and chronic pain, where we describe how it interacts with these different cognitive and emotional networks and descending modulation, and why it might be a good target for intervention for chronic pain. So meditation, we thought might be a good intervention to target the LPFC and other systems in the brain. What is mindfulness meditation? The standard definition of it is written on the top line: focused attention while practicing moment-to-moment non-judgmental awareness of the self. So this is taught in a standard course, typically John Kabat-Zinn 8-week mindfulness-based session, but there are other ways to learn mindfulness. It is associated with improved ability to achieve emotional balance and clarity of thought. And we thought that it might be really important to look at dose, just like we would with any pharmacological agent. We think with non-pharmacological interventions, dose is also an important thing to consider. So in our pilot study of mindfulness meditation for chronic migraine, we sent our patients to a 10-day Vipassana meditation retreat. So patients go to this retreat. It's a standardized mindfulness training where for 10 days you are essentially waking, meditating until you sleep. And that's your day. And so we did this as a pilot study. And I always get questions about how do patients put up with that for 10 days. So they love it, actually. And non-patients alike. I think I haven't done this myself still. I got to do it when I find 10 days. But any of our patients who made it through the first day made it through the whole thing. So sometimes it could be to get through that first day, non-talking, not having your phone or anything to write on or anything to read or anything to watch on TV. But once you get through that, what many of the patients had reported back to us was that they wished they had another week or another 10 days there, actually. So they learned the core tools of mindfulness, and so we followed them out at multiple time points in a longitudinal neuroimaging study. We're just pulling together all the diary data that we have for this trial, and that this will be published sometime in 2017. But here's a preliminary look at some of the outcomes. So this is migraine pain intensity. You can see there's a reduction immediately following the intervention or the retreat, and that's sustained after 6 months and sort of starts to rebound by 12 months. And we're not sure if that's because participants were no longer compliant and no longer meditating, or if something else had happened. And we see similar trends for a reduction in pain catastrophizing as well. So this is total catastrophizing scores, again, decreasing up to 6 months, and then a bit of a rebound. And when you break it down by the subscales, magnification and helplessness both show significant decreases. Of course, where I am most interested in the brain imaging correlates of this, have cognitive-related data that we're working up, as well as structural, so all of that will be coming. Here's just a quick look at some of the pain-related activations. So you do a thermal stimulation applied to the left forearm and all the patients and controls. And so you can see across patients and controls, these are the areas across the brain that are activated: mid-cingulate, bilateral anterior insula, and so on. Below what's sometimes referred to as pain matrix areas. But you can see that for some of the regions, patients activated the areas more strongly, controls, and that is over time. So part 2 is from an old talk that I didn't delete. I'm going to change this. So I'm going to talk now back to the themes. I'm going to development of chronic pain. So one of the challenges we have with looking at development of chronic pain is, unless you're doing a very well prospective study where you enroll many healthy individuals and expect 20 to develop chronic pain over time, you need to enroll a lot of people, and you need multiple sites and so on. So it's very difficult to control all of the factors that would go into that. So we turn to rodent imaging to address some of these questions. Well-known or well-described the changes that occur or the differences between the brains of people with chronic pain and healthy individuals. But what we want to know is what happens from this stage, pre-injury, to stage. And then, of course, we can look at how it reverts back to normal, again, in humans, or we could use a rat to find some intervention. So we do longitudinal imaging studies in rodents. The nice thing about using rodent models is that we get a true baseline where we're taking rats that are identical in both groups. We then do some, actually all three to show you our types of neuropathic pain models. And then we can follow the transition from acute to chronic pain. So going back to our brain systems, I fit all of this area into the shift to limbic circuits. So this is work that I did during my postdoc at McGill University, Catherine Bushnell. And we did that study with animals, and we scanned them pre-injury and then at multiple time points after injury, after 6 months after injury. We got two distinct findings from this. So first of all, there were brain regions that changed associated with sensory changes. So these were hyperalgesia-related changes in the posterior part of anterior cingulate and bilateral primary somatosensory cortex in the hind limb area. So these were spared nerve injury animals in which the part of the sciatic nerve is ligated. So they develop really intense hypersensitivity in the leg that's affected. And so the extent of change in these regions correlated with the extent of hypersensitivity that the animal showed. So those are sensory-related changes, but we also saw later on some anxiety-related changes. So these only occurred at very late stages. So at 4 and 5 months after injury, we started seeing reductions in gray matter volume in the prefrontal areas. So similar to what we see in chronic low back pain and other chronic pain conditions in humans. And interestingly, corresponded to a change in anxiety-like behavior that only started appearing at those same time points. So we think this is a pretty good model for that transition from acute to chronic. And here we see changes related to sensory and changes related to anxiety or other emotional changes. And so when I refer to the shift to limbic systems, I think what's happening is the brain changes that take over once chronification has occurred are really more limbic regions. So we did a similar study at University of Maryland, exact same model, but this time looking at functional MRI. So this is the same model, but we're looking at actions related to the application of a noxious cold stimulus to the affected hind limb. So early on, at 4 weeks post-injury, you see relatively increased activation of more sensory areas like the thalamus and the primary somatosensory cortex in the injured animals compared to sham. Later on, at 20 weeks, those changes are gone. Sensory changes are no longer there, and now we have changes that are more associated with limbic circuitry again, so more rostral, anterior cingulate, or medial prefrontal cortical areas. And we showed something very similar in a spinal cord injury model of pain, this time looking at resting state connectivity. Here, without going into the details, again, early on we see changes in primary somatosensory cortex and thalamus, but later on those changes disappear and there's more in emotional circuitry. So in addition to having shown this in animals, probably the best evidence for this change comes from von Yaftarian's group at Northwestern University, where they've shown in a number of different ways now in a study where they followed subacute back pain patients during the transition to chronic pain. So they actually did a very large study where people within a few weeks of an initial back injury followed them out to, as I think they're still following them, but the last time I checked it was out to 3 years. Early on, so these maps are a program that anybody can look at online called neurosense.org. And if you just type in the keywords pain, emotion, reward, you get these different networks that come out. So brain regions that are activated across many, many different studies. So they call this pain network, the sensory network. And you can see that early on, the subacute back pain activating the sensory network or pain network, and only a little bit of activation in the emotion and reward networks, whereas once the pain has been in the chronic low back pain patients, they're showing relatively little activation of pain-related areas and increased activation in emotion and reward areas. So more evidence for this shift from sensory involvement to more limbic or emotional circuitry. Okay, the third and final that I'll go over is maladaptive stress. So maladaptive stress, this is from a review by David Borsuk and Bruce McEwen. And Bruce McEwen has done a lot of work on the effect of repeated stress and came up with this term allostatic load. Allostatic load is essentially all the maladaptive cumulative effects of repeated stress. So thinking about stress, stress isn't always, our response to stress isn't always maladaptive, and in fact, it's actually there to serve an adaptive purpose. So in short-term stress, we could actually learn better, we might remember things better, we might perform better, and it can actually be analgesic. But with the repeated exposure to stress, you can actually sensitize the whole system and become hyperalgesic. So they use migraine as their model, which is a good model for exposure to repeated stressors. So you have repeated attacks. That's the main characteristic. So not only do you have repeated attacks, but you're always worried about lab is going to happen, and is it going to happen when I really can't afford it to happen? So having these constant attacks and no good way to prevent those attacks leads to a failure to habituate to those repeated stressors. And so neuroplastic changes start occurring. Essentially, you get a failure to shut down the stress response system. And so that leads to this allostatic load that is thought to be generally maladaptive. So in our lab, we have a model called the stressed grad student. I have 3 cases to show you: Shayna, Janelle, and Joyce. In the first, actually prior to PhD, this is what they all looked like, happy people. Here, PhD, things are getting tough, but these are resilient, bright women who adapt very well, and they're doing fine still. But later on into the PhD, things are hard. I have male students, but they don't fit this model, which is funny and not. But our question is, what are the effects of repeated exposures to these repetitive stressors? And working with Rich Traub in my department, who's really an expert in visceral pain, he developed this model of estrogen-dependent stress-induced visceral hypersensitivity. So this has been shown in several labs now, that in fact, to get visceral hypersensitivity, you don't need to create a pain model. You can just expose an animal to a repeat. The stressor in this case was a forced swim, so you drop a rat in water and have it swim for 10 minutes for several days in a row. And the output is the visceral motor response to colorectal distension. And these are standard measures done in Rich's lab. So like these are control animals, so this is the normal BMR. And after stress, the female rats, the naive intact female rats show a profound hypersensitivity to that same colorectal distension. If you give the female rats testosterone, they look like male rats, as in no response to the stress. If you give the male rats estrogen, they show a female response or even greater. If you ovrectomize the females or gonadectomize the males, females show no effect, males show something in between and female effect. And the hormone levels here were titrated to be what would be normally found in males and females when you do animals. You see the timeline a little bit, depending on the specific model that's used, but what intrigued me about this is that you get a real difference in hypersensitivity at some time point, and this doesn't show it this particular graph doesn't show it that clearly, but you usually have a return to normal after a given amount of time. So the stress effects wear off in this case. So I thought, what a great model longitudinal model to image, because we have animals starting off the same, very different time point, and then they return back to normal. So this is behavioral effects from the animals that we imaged. So you can see profound hypersensitivity in the estrogen-only animals. So the overactomized whom were given and others estrogen. The vehicle rats do not develop the hypersensitivity. We do colorectal distension inside the small MRI. This is the HRF-convolved stimulus response, and this is the response. So this is activity corresponding to, and you can see it's a pretty tight correspondence for fMRI, though, as good as you're ever going to get. We get bilateral activation of bilateral anterior and a mid-cingulate area, which is typical of this type of stimulation. And if we do a model that maximizes the difference based on these behavioral differences, the regions that come out are quite interesting. Ventral pallidum or ventral caudate. So this is really ventral striatum, which is an area that's known to be highly involved in the reward system. Medial thalamus, which is also thought to be involved in the more affective response to pain, the amygdala, and the hippocampus. So all areas that are more involved in the emotional response to pain or just emotion in general, rather than sensory regions. So again, this leads us to a good potential target. Stress reduction might be very useful. Mindfulness-based stress reduction, that might be a good intervention, I don't know. Exercise, we tried to do a mindfulness model in the rats. It didn't work that well, so we thought that maybe we could have them running on wheels. That might be mindfulness to them. They can, I don't know, put a better model in rats. And sleep might be really important. So we have ongoing studies now looking at interactions between sleep reward, assuming that the common mechanism underlying disorders of those three is related to dopamine. And here's your, I don't know if that's for the web extra for the audience.
If you're watching online and you want to submit for your CE credit.
Okay, there you go. CE credit people, 12546. All right, the final in the methods is looking at the difference between and ongoing pain. So as I mentioned, we see lots of differences between chronic pain patients and healthy individuals. Looking at the development of chronic pain sort of addresses whether those changes are because the brains of chronic pain, people who develop chronic pain and people who don't, were always different. And it just turns out that we captured them at a state where the one group has chronic pain. But we still don't know, particularly for functional changes, if these changes are related to the pain that they're experiencing in the scanner or if the brain has really changed over time. So we have a really interesting clinical model to address this problem. Burning mouth syndrome is another clinical population study. Can I do every talk I give? I have to audience to see how many people have heard of burning mouth syndrome. So I'm seeing 30%, maybe 40%, which is pretty good. That's pretty good. I've given talks to groups that were mostly neurologists and had very few hands going up. Alarming in a way, because it's when I first described this, I was describing a rare disorder. It definitely doesn't meet the criteria for a rare disorder. It's better described as an unusual disorder. That's probably misdiagnosed. It is the name of the syndrome describes the symptoms quite well. It usually affects the tongue or hard palate or lips, but it can really be anywhere in the oral mucosa. And it's usually bilateral, and it does not follow a nerve distribution in any way. This figure ranges a lot, the prevalence, but the one that we decided on was 4.6 in the general population, and the male-female ratio, female-to-male ratio is really high. Some have even said this is as high as 33 to 1. It appears primarily in postmenopausal women. So we study this only in postmenopausal women, and what was really interesting to me initially is that there are two, it's accepted in the literature that there are two types of burning mouth syndrome, and BMS type 2 is most consistent with other neuropathic types of pain, where the pain is constant throughout the day, it affects their sleep, it's unrelenting, it's always there. And BMS type 1, patients generally wake up in the morning pain-free. As the day goes to about mid-afternoon to early evening, it becomes spontaneous burning pain, becomes maximal. And then as the night goes on, it breaks and patients actually sleep pretty well through the night. Different than any other chronic pain that I'm aware of, but it's extremely consistent pattern. It's about 50-50, type 1 and type 2, but from the we've seen that have been really screened to ensure that they do have burning mouth syndrome, I'd say it's more like 70% with type 1. That's not a figure to be cited anywhere. That's small sample like most of the burning mouse data out there. But what this looking at type 1 really gave us was an opportunity to study the differences associated with chronic pain and effects of ongoing pain. So we can look at the effects of chronic pain by comparing patients to health the way that we do in all of our studies. That we can also compare the brains of patients at the different time points, so late afternoon to early morning, as early as our school was to start. But we got a good differentiation between pain between these two times in all the patients. So we could just really see the effects of ongoing pain within those patients. So this is the summary of the first study that we published, and moving up our second funded study on burning mouth syndrome, which is the only, at least NIH-funded study currently. So it's a problem for sure. So comparing patients to healthy controls, just looking at gray matter volume, we see increased hippocampal volume and decreased prefrontal cortical volume. So these are findings that have been reported in other orofacial and other types of chronic pains. When we look at functional connectivity, so this is resting state, lying in the scanner doing nothing, we see connectivity between the medial prefrontal cortex and, again, the right hippocampus. And we see this difference between controls, and we see this difference within the patients where this increased in the afternoon compared to the morning. But there was no difference between in the morning and control. So when that ongoing spontaneous pain is present, there's no difference in resting state connectivity. And interestingly, the extent of this connectivity correlated really strongly with depression ratings on the Beck Depression Inventory. So I didn't even draw a line through it here. You can see it holds very well for control and patients, where the more strongly you rate your depression symptoms, the more strongly connected these two regions are. So here we're distinguishing effects of patients versus controls and effects that can be assumed to be related to the ongoing burning. This relationship between hippocampus and medial prefrontal cortical coactivation or connectivity has been shown by other groups. So interestingly, this group by Etienne Vachon-Brasseau, University of Montreal, showed that in chronic low back pain patients, there's activation of the hippocampus that wasn't seen in healthy subjects. And the extent of this activation correlated with the cortisol levels in those patients. So the higher stress response they're showing, the more activation you get in the hippocampus. Similarly, Petra Sveinhardt has shown in rheumatoid arthritis that the activity between medial prefrontal cortex, which is associated again with BDI scores, and hippocampus, and that connectivity was actually related to BDI as well. So that sums up this portion of the talk, and I'm going to talk about some of the ongoing models. So I wanted to wrap up this part by saying I've shown the three different methodologies, launch that we use, and the three different general systems that we focus on. And I think from those studies we learn what interventions are going to be effective, maybe for patients, is leading towards individualized medicine. Maybe it's more relevant to certain types of chronic pain conditions. We don't know exactly, but a lot of my work is focused on non-pharmacological intervention of chronic pain. And essentially what we're trying to do is one of these three things. Can we improve network function, maybe through cognitive training? Can we break the cycle that's associated with maladaptive stress? Can we prevent that shift to limbic circuits early on so they don't develop chronic pain? I will wrap up. I don't have a clock anywhere. I was asked, oh, it's right there. Okay, so 3 minutes for questions. I'm going to wrap up with a discussion of some of the models of ongoing pain that we have. So I've shown that disruptions are present. They're present in pain. If we use models of ongoing pain, are they more similar to the chronic pain or the acute pain in healthy subjects? So by ongoing pain, I'm referring to something different. I don't know exactly what it is. We have some models that produce pain that can last 90 minutes, and I'm now working with some models of muscle pain that can last a few weeks. And we think that there's something about these pain models and the way that pain is typically done experimentally, where we're applying phasic stimuli that usually last between 10 and 45 seconds or even a few minutes. So I'll share those with you and what we're attempting to do with them. So oral burning is a model that we really want because these burning mouth syndrome patients are very hard to get, and it's a tough disease to study. So if we have a good model that we can use, I should be very happy with this. So this is work that builds off of Barry Green's model, 90s, that our own lab where we apply capsaicin to the tongue. We call it our oral capsaicin syndrome. And we filter paper dipped in of capsaicin and apply it to the tongue repeatedly every minute and get pain ratings. And you can see that you get a pretty constant burning pain, and this is two subjects for both burning intensity and burning unpleasantness. As soon as we take the stimulus away, it rapidly returns back down to 0 after a few minutes. So that's a good thing. We don't think it's damaging anything. These are old data. We have this updated by quite a bit. Patient response, I don't know if that's overlap, but it might not be surprising to have some ongoing pain when we do it in them. Able to achieve this ongoing burning pain in healthy individuals. And when we asked patients what it felt like afterwards, quite a few of the patients replied that this is it. You've replicated what burning mouth syndrome is. So we're really happy about that because ultimately we want our models to have some similarity to the disease model that we're trying to replicate. We can also apply capsaicin to anywhere on the body, routinely on legs. We use a 10% capsaicin cream, apply it to and let it incubate for 15 minutes. This is a model worked up by Johns Hopkins in the 90s. We apply therm mode to that area that's been sensitized, and now that warm therm mode that's normally not painful at all is moderately to intensely painful. And we can maintain that out to 90 if we're cruel enough. Here we're showing what across 25 minutes in the incubation ends, and you can see that it's a pretty steady pain across individuals. So what can we do with these models? We can do all sorts of things. We can do the same kind of things we did in patients for controls and see if this changes connectivity, if it changes cognitive-related activity, and even changes the pain activity. More and more EEG. The first things that we've been able to show with this model is that it can actually affect an individual's pain sensitivity to the model about an hour and a half or 2 hours before we ever do any manipulation, before we ever apply pain. So we're looking at a metric called alpha frequency, which is sort of an easy metric to use and has been linked both basic pain and to chronic pain. In chronic pain, it's alpha frequency shifts right lower frequency, and that after resolution of the pain through nerve, it will shift back to the. We think that our on is actually reflective of temporary neuropathic type of pain. That the more you get that shift to the right, the more intense pain is. This is both at the time point before we apply the capsaicin, so that earlier, and this is when they're actually experiencing the pain. So we down into our pain sensitive people and high pain sensitive people, and you see that in the high pain sensitive people, there's this pretty strong shift to the left, so to lower, just like was seen in neuropathic pain patients. And it didn't matter whether we during the pain or prior, we were able to predict the pain intensity that they would experience. So that's some of the ongoing work. A lot more. But that's what I wanted to share with you. So these are the people that in my lab and across Canada and around the world. And thanks for staying awake, everyone.
That's great. Thanks very much, David. We do have time for a few questions, and if there is a question from online from the WebEx group, it'd be great. I'll come over and take a look at that to you. But in the meantime, any questions from the audience here?
Yeah, so the question are attention and cognition the same thing. Did I paraphrase that well enough? So attention is a moment thing that's kind of hard to describe. You can do many things in many different ways. Actually teaches learning to. And when you suddenly become aware of all the things that you attend to, it turns out that you're constantly things. The training with mindfulness is to try to let that go, to let it those things be, with giving them any attention. So to me, it was a bit of an abstract concept, whereas attentional, we're really referring to the difficulty of a task and how much effort you put forth to perform that task. Clearly overlap between the two concepts, but that's how we've defined them. Right. The question again is dorsolateral prefrontal cortex. What does it do? That's a great one. And why is it realizing left and not to the right? What does it do is a very big question. It's our higher order thinking. It doesn't in rats, for example. So that's one of the limitations of moving to some of the areas that we look at in humans don't actually exist or don't have analogs in rodents. So because of it, it has an order function and is highly connected to it's hard to get a function. We know it has a really important role in descending modulation of pain and in descending modulation of function. So why the left? That's a harder question. There's some theories out there that the lateralized left and right based on positive and negative emotion and so on. And you can sort of wave your hands around that, whether you buy it or not. But I would say that we don't know, but the left seems to keep coming up. FDA approved treatment. I'm sorry for the hesitation, but treatment for major depression is RTMS of the left, DLPFC. And that's excitatory stimulation, although you can do inhibitory of the right, DLPFC, and it seems to be just as effective for at least some patients. That's about as much as we know. Yeah, absolutely. This is where it gets a little, because I mentioned that PFC borders extrinsic mode and default mode network. So on the middle frontal gyrus, that's that executive, and the more superior part is more related to whatever you think the default mode is doing, internal representation of autobiographies and so on.
Okay, so there's a question from Ian Roger, who's listed on the WebEx. The question is repeated application of capsaicin to the point of desensitization used clinically. Then look at the concert MRI changes. So after the desensitization.
That's a great question. We have not looked at it. Question two. Okay, so it's a long one. Have we used capsaicin repeatedly, as is done clinically, in disorders like postherpetic neuralgia and other neuropathic pains to actually desensitize an area rather than sensitize it? We haven't. We do one application, and these are repeated measures. So we bring people back after 3 weeks when we think that the nerve damage that this causes has the nerves have regenerated. It's an interesting question, though. If we understand the brain mechanisms of not only hypersensitivity but analgesia, that's something that eventually we'll have to look into.
Hello, can you hear me? Can you hear me there? Hello, can you hear me?
Roman?
Yeah, can you hear me?
Mic's on now. And speak.
Okay, can you hear me? Hello, can you hear me? Hello, hello. Can you hear me? Can you hear me? Hello?
Yeah, we can hear you now, Roman.
Okay. So I have a question for David. I met a very interesting patient. Have you thought or have you met anybody who had aromatase inhibitor arthralgia? Which is intriguing because they have burning pain, sort of like neuropathic pain. They have a little bit of gelling, you know, if they don't move around, they get worse. And you can't see any redness, no swelling, no other markers of inflammatory arthritis. And of course, the aromatase inhibitors inhibit estrogen production. So I was listening earlier to your model about de-estrogenizing rats. So I don't know if you're familiar with that clinical condition.
I'm not familiar with it. I've never done with it, but it's sticking to me. That's something I should. Yeah, I don't know. A follow-up to that, Roman?
It's rare, supposedly, but in my little bit of literature searching, anywhere between 30% and 40% of women who have breast cancer and get aromatase inhibitor therapy develop this. So you should be able to find lots of subjects.
The subject sounds wonderful. But yeah, that's next week. That fits very well with, yeah, as you saw, all of our hypotheses about the role of sex hormones. And questions come up a lot with burning mouth syndrome, too. It affects mostly postmenopausal women, like I said. Replacement therapy doesn't see any association with pain relief. Replacement therapy. So I'm sure there's some role of sex hormones, but without exactly what that is. Keep looking like you said.
Okay, thank you, everybody. If you're in the one you have not yet seen or filled out an evaluation form, please. If you are on, I think we're not quite set up for this yet, but if you, we know who was on. Happy to forward the attendance certificate accreditation for your continuing education record. If you were on the WebEx, please email us back with any comments that you have about it. This is if we've done it, but it's something we hope to do. And I forget if we've done it this time. We only work webinars available on the websites, both for the DeGroote Pain Clinic and in the DeGroote Institute for Pain Research and Care for future viewing. So thank you very much. And thank you, David.